Good day. Now we are going to have our fourth lecture on topographic anatomy and operative surgery. Today's theme is topographic anatomy of the anterolateral abdominal wall. So the borders of the abdomen, upper diaphragm, lower the borderline, linea terminalis. It is a line of the inner surface of the pelvis formed by a cape, arched lines of the iliac bone, rigid pubic bone, and the upper edge of the pubic area. Symphysis serves as the boundary between the large and small pelvis. Back lower, back, and front side. So the borders of abdomen, upper the diaphragm, lower the borderline, back, lower back, and anterolateral. So the same. The abdominal cavity. It is the space line with the intra-abdominal fascia. It contains the retroperitoneal space and so it contains the retroperitoneal space and the peritoneal cavity with internal organs, vessels, and nerves located in them. Peritoneal cavity is the space located between the visceral and parietal layers of the peritoneum, contains the digestive organs and the spleen. Retroperitoneal space. It is the space located behind the peritoneal cavity. It contains the kidneys with uterus, adrenals, glands, pancreas, most of the duodenum, large abdominal vessels and nerves, abdominal aorta, inferior vena cava, solar plexus, sympathetic trunk. Abdominal wall is formed by the muscles of the abdomen, distinguished between anterolateral wall of the abdomen, massage area of the abdomen, and back wall is a part of the massage of the lumbosacral region. Anterior abdominal wall is the border from above restricted hyphoid process and costal arches, right and left arterial vertical line connecting the end of the 11th ring with the iliac crests, less graft line below, symphysis of the pubic bones, inguinal fold, and ridges of the ilium. Conditional conduct two vertical lines passing through along the outer edge of the rectum abdominis. Then conditionally draw two horizontal lines at the top between the lowest point of the edge arc, linea bicostalis. This is it. And below, between the upper anterior iliac ons, linea bispinalis. So this is it. Two vertical lines passing through along the outer edge of the rectus abdominis. Thus, the anterolateral wall of the abdomen is divided into three sections: upper epigastrium, average mesogastrium, and lower hypogastrium. In the upper section, there are actually epigastric, regio-epigastrialia propria, as well as the right and left subcostal areas, regio-hypochondriaca, dextra and sinistra. The middle part consists of the umbilical region. Right and left areas, regio lateralis, abdominalis, dextra, et sinistra. There are also 3 areas of the lower part: the pubic area, regio pubica, right and left, ilioinguinalis, regio inguinalis, dextra, et sinistra. Projection of organs. The epigastric region proper, stomach, part of the body, and pyloric region, liver, small oil seal, the pancreas, duodenum, its upper half, and duodenal band, aorta, the solar plexus, sometimes 1/3 of cases. The right pleural cavity is near the right costal hyphoid angle. In most cases, the left costal hyphoid angle has a section of the pericardium that is not covered by pleura. Right subcostal region. Most of the right lobe of the liver, the gallbladder, right band of the colon, upper pole of the right kidney, left subcostal region, bottom, cardia, part of the stomach body, a small part of the left lobe of the liver, the spleen, tail of the pancreas, left band of colon, upper pole of the left kidney, the umbilical region, loops of the small intestine, transverse colon, lower horizontal and ascending parts of the duodenum, large curvature of the stomach, kidney gate, ureters, large oil seal, aorta, infernal vena cava, right side area, ascending colon, loops of the small intestine, right kidney, and right ureter. Left side, descending colon, loops of the small intestine, left kidney, and left ureter. Pubic area, full bladder, ureters, loops of the small intestine, pregnant ureter, part of the sigmoid colon extending into the rectum. Right groin area, second with the vermiform process, terminal ileum, and right ureter. Left groin area, sigmoid colon, loops of the small intestine, and left ureter. The projection of organ depends on body types, age group, and body position. External landmarks, the edges, the navel, iliac crests, anterior-superior iliac awns, pubic bumps, symphysis, inguinal folds, outer edges of the rectus abdominis muscles. Also depends on, is it inhale or exhale? Pleurum abdominal. Abdominal press, a set of abdominal wall muscles involved in regulation of intra-abdominal pressure. The main abdominal muscles are the externals and internal obliques, transverse, rectus, and pyramidal. The role of the anterior abdominal wall: improve external respiration, promote blood circulation regulation, intrathoracic and intra-abdominal pressure, motion activity of gastrointestinal tract, layers of anterior abdominal wall. In the anterior abdominal wall, there are superficial, middle, and deep layers. The surface layers. The surface layer includes the skin, subcutaneous tissue, and superficial fascia. Middle layer. The middle muscular layer of the anterior abdominal wall consists of straight, oblique, and transverse abdominal muscles. They are located along the entire length of anterior abdominal wall and are fairly thick muscles plate that support the abdominal viscera. And deep layer, the deep layer of anterior abdominal wall consists of the transverse fascia, preperitoneal fiber, and peritoneum. The surface layers of anterior abdominal wall, skin, thin, elastic, firmly fused in the navel area with the umbilical ring, and scar tissue, which is remaining of the umbilical cord. Subcutaneous fat about the navel of the form of 1 to layers more develop on the lower parts of the abdominal wall, the 3-4 layers. Superficial fascia below the navel consists of 2 leaves, a superficial and more developed deep one, Thompsonova Street, a record. The surface leaf continues to the anterior third area. The deep leaf is attached to inguinal ligament. Superficial hematomas and phlegmons spread to hip, deep limited to the inguinal ligament. The structures of anterior abdominal wall at the level of the navel. Surface layers of the anterior abdominal walls. Rectum, cutaneous lateralis, pierce it external oblique muscle at the level of anterior axillary line at anteriors. Punctures the vagina rectum abdominis, nerve intercostalis. Rus cutaneae anteriors et lateralis, nears iliohypogastricus. Arteria et vena pudenta externa, vena femoralis, arteria et vena epigastrica, lateralis cutanea and arteria intercostalis posterior, and vena thoracica epigastrica. Middle layers of the anterior abdominal wall, muscular oblique externus abdominis, muscle rectum abdominis, intersector tendina, aponeurosis muscular oblique extremity abdominis, muscular pyramidalis, funiculus spermaticus, nerve ilioinguinalis, rupa rami cutanei anterior et lateralis, nerve iliohypogastricum, anterior vagina wall, muscle rectus abdominis, ramine cutanei anteriors et lateralis, neuro intercostalis. Layer by layer structure of the lateral parts of the abdominal walls. External oblique abdominal muscle, internal oblique abdominal muscle, transverse abdominal muscle, and also you see the fiber direction on the right. So as you see, the directions of the lateral anterior abdominal wall muscle fibers, layer by layer. Middle layer of the anterior abdominal wall, arteria et veins, epigastrica superior, posterior vaginal wall, muscle recti abdominis, arteria and vena intercostalis posterior et nerve intercostalis, muscle transversus abdominis, nerve iliohypogastricus, linea arcuata, arteria et vena epigastrica inferior, muscle rectus abdominis, nerve ilioinguinalis, muscle obliquus internus abdominis, aponeurosis muscle oblique interni abdominis, Front and rear walls, vaginas, muscle erecti abdominis. Anterior abdominal wall. Blood supply to the anterior lateral abdominal wall. The transverse blood supply system of the anterior lateral abdominal wall is represented by 6 lower posterior intercostal arteries, arteria intercostalis posterior, extended from the thoracic aorta. 4 lumbar arteries, arteria lumbalis, segmentally extending from the abdominal aorta, perforating branches, rami perforantes, interior thoracic arteria. Venous anastomosis of the anterior abdominal wall. Cava-cavum anastomosis from the lower part of the anterior abdominal wall to the inferior vena cava system. Vena epigastrica superficialis in the navel area. Vena pudenda externa, vena circumflexa ilium superficialis into the femoral vein. From the upper part of the anterior abdominal wall to the superior vena cava system, vena epigastrica superficialis in the navel area, vena thoracica epigastrica, and then in vena thoracalis lateralis or in vena axillaris. Porta cavum anastomosis. In the navel area, vena epigastrica superficialis, through which the outflows goes to the system of the upper and lower vena cava. Anastomosis, it with vena paraumbilicalis, located in the round ligament of the liver and forms a link between the vena cava and the portal vein system. Caput medusa, it's medusa's head. Anterior abdominal wall. The following nerves are involved in the innervation of the anterior lateralis abdominal wall areas. Skin, nachervia, epigastrium, innervate the branches of the 7th to 9th intercostal nerves. Skin, среднее чрево, or mesogastrium, branches from 10 to 11 intercostal nerves. Skin, подчревье, hypogastricum, branches of the subcostal nerve, nerve subcostalis, as well as branches of iliohypogastricus and ilioinguinal nerves from the lumbar plexus. Posterior surface of the anterolateral abdominal wall. Median umbilicalis fold, median umbilical ligament, parietal peritoneum, medial umbilical fold, lateral umbilical fold, lateral inguinal fossa, medial inguinal fossa, nadpujная fossa, bladder, ureter, vas defender, inguinal sickle, external iliac vein, external iliac artery, deep inguinal ring, межямочковый street ligament, lower epigastric artery and vein, posterior leaf of the rectus abdominis vagina, rectus abdominal muscle. Hernias, weak point of the anterior lateral abdominal wall. Structure of the inguinal canal. The inguinal canal has 4 walls and 2 openings. Walls of the inguinal canal. Anterior, aponeurosis of the external oblique abdominal muscle. Posterior, formed due to aponeurosis of the transverse abdominal muscle and transverse fascia. Approximately 1/3 or 1/4 of the posterior inguinal wall is not covered by aponeurosis of the transverse abdominal muscle and is a weak point. It is this part that is located above the comp ligament and the place of transition of the iliopubic tract to the lacuna ligament. upper overhanging edges of the internal oblique and transverse abdominal muscle, between the aponeurotic arch of the internal oblique and transverse abdominal muscles, from above the lumbar muscle laterally, the pubic bones from below, the outer edge of the rectus abdominis vagina, medially there is another weak muscle scallop opening, a lower inguinal ligament. Anterior abdominal wall. The inguinal canal, it's a 4 centimeters tunnel in the lower anterior abdominal muscle that runs downwards and medially between the deep and superficial inguinal ring. Anterior wall, external oblique and internal oblique for lateral 1/3 roof. Arching fibers of internal oblique and transversive and posterior wall, transversal fascia and conjoined tendon. The floor is inguinal ligament. External opening of the inguinal canal, otherwise the superficial inguinal ring. Annulus inguinalis superficialis. It has a triangle shape. The base of the ring lies on the upper branch of the pubic bone, ramus superior ossis pubic, and the side are formed by split aponeurosis of the external oblique abdominal muscle in the form of medial and lateral legs. The slit-like opening between the medial and lateral predicels is bounded externally by interleg fibers, fibra intercruralis, extending from the middle of the inguinal ligament up and medially to the white line over the abdomen, and from below and behind a curved ligament, ligament reflexum colisi. In healthy men, the slit-like opening passes through the tip of the index finger. Internal opening of the inguinal canal, otherwise a deep inguinal ring, is an opening in the transverse fascia through which the spermatic cord passes. The hole is formed not due to perforation of the transverse fascia by the spermatic cord, but as a result of the fact that the spermatic cord drags the fascia with it and forms a funnel-shaped protrusion of it like a glove fingers. Fascia infundibulariformis. Thus, from the transverse fascia, the common vaginal membrane of the spermatic cord and testicle is obtained. Fascia spermatic interna. Anterior abdominal wall. Outside, along the spermatic cord, within the inguinal canal, nerves pass from above the ilioinguinal nerve, below the sexual branch femus, sexual nerves. Ramus genitalis, nerva genifemoralis. In women, there is a round uterine ligament in the inguinal canal, ilioinguinal nerve, and the sexual branch femur, sexual nerve. Ramus genitalis, nerva genifemoralis. Signs for definition forms belly button. Index verticalis, index transversalis, angulus subcastalis, shape подчревья. Vertical belly index, index abdominis verticalis, distancia hyphoide pubica, divided by distancia pubica, multiplied by 100%. In norm for men, it is less than 66. for women, more than 72%. The next index, abdominis transversus. It is distante castarium divided by distante spinarium multiplied by 100%. Form belly button. Men's clothing laterally more than 100. Cylindrical latitude 100. And the woman's clothing latitude less than 100. Angulus subcostalis. For men, it is 84 degrees. For women, 79. The shape of the anterior abdominal wall depends on belly shapes, chest shapes, pelvic shapes, gender, and age group. So this is the examples of the shapes of abdominal wall. Pear-shaped, ovoid, and pear-shaped on the contrary. Pear-shaped is individuals with narrow chest and wide pelvis. Ovoid, often seen in newborns and children under 7 years old. And pear-shaped, on the contrary, individuals with broad chest and narrow pelvis. It is most common in men and in the male form of the pelvis. Belly shaper, men's clothing, women's clothing, and cylindrical. Belly shapers, once again, in one table. So it is also depends from the age. Features of the male form of the abdomen contrasting to the female form, narrowed in one linear alba, wider upper and middle rectus muscles, smaller area of lateral muscle free areas, large size of the superficial and deep inguinal rings, longer and higher inguinal spaces, less involvement in the internal oblique muscle in the anterior wall of the inguinal canal. The strength of the anterior abdominal wall is determined by muscle layer, neurotic layers, fast cell structures, and the presence of weak points. Loci minoris resistante. It means weak points of the abdominal walls. They defined by reducing the number of layers in the wall, muscles mainly, transition of structures from one cavity to another. A hernia, it is an exit or protrusion of an organ from the cavity where it is located through a congenital or acquired opening. Classification of hernias by anatomic features. Hernia inguinalis, femoralis, umbilicalis, line alba, line spigili, lumbali, perineuralis, and diaphragmalis by ethology. Hernia congenitalis, esquata, purchased item, hernia preforma, or herniated weak points, hernia postoperative, hernia recidiva, hernia traumatica, and hernia neuropathia by clinical signs. Hernia reponibus or settable, and hernia irreponibus and not corrected, and hernia in characteristic or aggressive. Aggrieved. On the picture where the hernias are located and named by their location. Hernia always have a hernial sac. I will draw it. So the hernia always have hernia sac. This is it. Hernia gate. This is it. And hernial content. This is hernial content. Loci minoris, resistance, upper wall of the abdominal cavity, diaphragm, spatium sternocostale, sinistrum, slow-area, narrows triangle gap between the sternal and costal part of the diaphragm, filled with fibrous spatium sternocostale dextrum, triangle Margani, and spatium lumbocostale, space Bandaleka. This is spatium lumbocostalis on the space Bandaleka. Loci minoris resistance, upper wall of the abdominal cavity. Hiatum aorticus, aortodiaphragmatical canal. Hiatus esophageal cleft. Foramen vena cava, opening of the inferior vena cava on the pictures. Front wall, trigonium hypochondriacum aponeuroticum, Walensky's triangle, linea alba abdominis, high lineal arcuata Douglas annulus umbilicalis, vagina musculi recti abdominis, linea semi lunaris spigelis, trigonum inguinalis, fossa inguinalis lateralis, fossa inguinalis medialis, and fossa supravesicalis. Trigonum hypochondriacum aponeuroticum, trigonum Walensky triangle, topographic and anatomical landmark, weak spot of the anterior lateral abdominal wall, filled with fiber and only covered in front by the tendons and partially by the muscle fibers of the external oblique abdominal muscle. There is no aponeurosis internal oblique muscle, belly button. Genki line, outer edge, muscle rectal abdominis, section of the costal arc. The triangle contains 7, 8, and 9 intercostal nerves. The Walensky triangle. Front wall, linea alba abdominis. This is it. Along the midline, the aponeurosis of the oblique and transverse muscle of the right and left side cholestic with the formation of the white line, linea alba. And on the picture is it is number 3, extending from the hyphoid process to the pubic. Males are less broad than females. In men with the brachiometric type and the male shape of the abdomen, the widest. With the cylindric shape of the abdomen and the dolichomorphic type, the narrowest. Slits of the white line of the abdomen are more common for women, for elderly. With age, the white line of the abdomen expands. In men, about the navel. In women, at the level and below the navel. what happens with the age, fluttering and widening of the rectus muscle, elongation of aponeurosis, muscle obliquus, abdominis, externus, internus, and muscle abdominis transversus. Hernia line, alba abdominis, hernia of the white line of the abdomen, linea alba, white belly line, porta hernialis, hernia ingeus gate, and Cosmotia hernials. Hernia contains fragment of a large omentum. Saccus hernias, hernical sac, and the fifth umba, the navel. Trigonia, the next annulus umbilicalis. The white line of a newborn has a defect, the umbilical ring, annulus umbilicalis, in the lower part of which there is a primary urinary passage and umbilical arteria. The umbilical opening of the newborns from the front side during the period of scarring of the navel. The hole lying above it serve for the passage of nerve trunk. After the umbilical cord falls off the umbilical ring, it is tightened by scar tissues, the so-called umbilical scar. In the lower half of the ring, the umbilical scar closely fused with the ligaments, more dense; in the upper half, more pliable. Umbilical fascia, a part of the intra-abdominal fascia, consists of transverse fibers and fuses with the peritoneum and rectus muscle sheaths. May completely cover the umbilical ring, may end above it. On the pictures, urachus and arterias umbilicalis, vena umbilicalis, the hole through which vena umbilicalis penetrates through canales umbilicalis, fascia umbilicalis, and her fibers form canales umbilicalis. And the fifth, fat cell hernias between the fibers fascia umbilicalis. Linea arcuata Douglas. The line clicks through muscles on the anterior wall of the vagina rectum abdominis called linea arcuata. Douglas James Scott, an outstanding anatomist and a practical physician, he left a number of classical work on anatomy and surgery. Of which the most remarkable are myograph compared specimen, a description of the peritoneum, a history of the lateral operation of the extracting the stone. All of his works were translated into Latin, French, and other languages. The languages have retained their meaning to this day. Linea arcuata, linea semilunaris spigeli. It is located at the line of transversal fiber transitions abdominal muscle in the tendon stretch, which passing behind the rectus abdominis muscle takes part in the formation of the posterior wall of her vagina and the white line of the abdomen. The line, it has a crescent shape. Spigelius, Belgian anatomist and surgeon, born in Brussels. He studied medicine in Louvain and anatomy in Paguana under first Fabricus, professor of anatomy in Venice, state doctor in Moravia. In 1627, published a treatise on an anatomist person. The next, Trigonium inguinalis, The border is the part regio-inguinalis from A to E, ligamentum inguinalis, from B to E, margo lateralis, from C to D, a horizontal line, a border between the middle and the outer part of inguinal ligament, and F is in inguinal space. So the relation to the inguinalis ligament of the transverse abdominis muscles. The internal inguinalis ring. The content of the inguinalis canal. For men, it is spermatic cord. For all, contains fat content. For women, it is a round ligament of the uterus. Prerequisites for occurrence of inguinal hernias in men, that is, features of the male shape of the abdomen, age-related changes in the reference data, front wall structure. Height of the inguinal space for men from 1/2 to 4 centimeters, for women from 1/2 to 2 centimeters. Relative length of the inguinal space for male form, it is 44%, for female form 39%. The variance of structure of inguinal space for a healthy person. Muscle obliquus internus abdominis goes low and strengthens the front wall of the canal. Edge muscle obliquus internus abdominis located in the channel higher for potential use hernia carrier. This how it is look. Canalis inguinalis permits the anterior abdominal wall from deep to superficially growing ring. Canalis annulus inguinalis internus crus mediale fibra intersecuralis cras lateralis. Deep inguinal ring located at more laterally, arteria and vein epigastric inferior, which form plica umbilicalis lateralis on the posterior surface of the anterior abdominal walls, corresponding to the lateral inguinal fossa, and opening in the intra-abdominal fascia through which the spermatic cord passed in man and the round ligament of the uterus in woman. Deep inguinalis ring, annulus inguinalis profundus, in the posterior wall of the inguinal canal, generated by transverse fascia, converging from the edge of the ring on the inner surface. Here we find fossa inguinalis lateralis. Surface ring, or annulus inguinalis superficialis, generated by the department from external aponeurosis oblique abdominal muscle, two legs, cras lateralis and cras mediale. The canal through the deep inguinal ring, the main passes ductus defendus and the neurovascular bundle. In women, ligament and teres uteri and the neurovascular bundle. The canal has 4 walls: the front page aponeurosis of the external obliquous muscle, backdoor transverse intra-abdominal fascia, the upper one lower edge of the internal oblique, and transverse abdominal muscles, the lower one inguinal ligament. Due to the absence of woman spermatic cord, superficialis inguinal ring has small size, and it can't significantly weaken the anterior abdominal wall. Thus, in a woman, it is extremely rare there are problems with the inguinal canal. Canalis inguinalis. The walls of the inguinal canal are formed muscular, aponeurotic, and fascial layers of the abdominal wall. One diagram of the structure of the inguinal canal in healthy and patient suffering from inguinal hernia on a sagittal section. Stomach contents that come out through the weak points of the abdominal wall is called a hernia. Oblique inguinal hernia, the inner hole of is fossa inguinalis lateralis. Direct inguinal hernia, the inner hole is fossa inguinal medialis. So this is lateral fossa, exist point of oblique inguinal lateralis, and medial fossa, exist point of direct inguinal hernia. For older men, changed to support structure the front wall leads to increase the frequency of direct inguinal hernias, disasters of the rectus abdominis muscles, epigastric hernias, and umbilical hernias. Canalis femoralis. The posterior wall of the abdominal cavity is trigonum lumbalia, Petrit's triangle, and lumbar rhombus, Lesgraft Greenfield. This is a trigonum petiti, rhomb Lesgraft Greenfield. Locking minoris resistance in big pelvis, canalis inguinalis, lacuna musculatorium, lacuna vasorum. In small pelvis, canalis obturatorius, foramen superiorme, foramen infraperiorme, piriforme, and foramen ischiadicum minus. Age-related chindles, extending the white line, increasing the number of slots in it, expansion of the superficial inguinal rings, aponeurosis of the external oblique abdominal muscle becomes less strong. Increases at the height and length of the inguinal space. The transverse fascia become flabby and weakly stretched. With age, the height and relative length of the inguinal space increases in men more than in a woman. Hernia of anterior abdominal wall or external abdominal hernia is the exit of the intestine from the abdominal cavity together with the parietal leaf of the peritoneum through natural holes in the muscle aponeurotic layer or through an opening in the same layer formed as a result of surgery or trauma. Methods that strengthen the anterior wall are applicable only for very small oblique hernias. When the inner inguinal ring still has a normal diameter in patients without a sign of congenital connective tissue weakens. Only in this category of patients with the risk of relapse be minimal when using these methods. Such hernias in the discussed contingents of patients are quite rare. This is the prerogative of pediatric surgery. All other hernias requires strengthening in one way or another. The posterior wall of the inguinal canal and the formation of an internal inguinal ring. Among the methods of plasticizing the posterior wall of the inguinal canal, we consider the method of Kujanov and Schuldes, two raw versions. Using non-absorbable monofilament threads is optimal. They are the most physiologically and have proven their effectiveness in the large groups of patients with strict indications. We prefer Schuldes method mainly because of advantages of a continuous seam. Their use is advisable for oblique inguinal hernias with the expansion of the inner inguinal ring, but the posterior wall of the inguinal canal is preserved. Usually, these are small recent hernias that do not descend into the scrotum with a well-defined posterior wall of the inguinal canal determined by finger examination. It is advisable to use these techniques for direct hernias that develop as a diverticle of the transverse fascia. Components of abdominal hernias. First, hernia gate, hernia content, and hernia sac. Uncomplicated hernia and non-recoverable hernia. So on the left, it is uncomplicated, on the right, non-recoverable. Special types of infringements, ridges wall mounted, W retractable, litra merely diverticulum. Pinched inguinal hernias. On the right is pinched. External oblique inguinal hernia. The hernial sac along the spermatic cord descends from the superficial inguinal ring in man into the scrotum and in women into the fibula of the labia majora. In cases of acquired oblique inguinal hernias, the hernial sac is located separately from the testicle. The hernial sac is covered with scrotum skin, fleshy membrane, superficial fascia, testicular lifting muscle, transverse abdominal fascia. Has a tendency to infringe. Most often they are one-sided. External oblique inguinal hernias requires protrusions of the hernia sac occurs in the areas of the lateral inguinal fossa through the deep inguinal ring. The hernial sac passes through the entire inguinal canal, has an oblique directions and lies parallel to the inguinal ligament. The hernial sac is located laterally from the lower epigastric vessels and is covered by the internal seminal fascia. The hernial sac is located laterally from the spermatic cord. The contents of the hernial sac enters the thickness of the spermatic cord elements, delimiting them. Congenital inguinal hernias are characterized by the following clinical and anatomical features. The vaginal process of the peritoneum is congenital inguinal hernia, is both the hernial sac and the vaginal membrane of the testicle. Protrusion of the hernial sac begins in the area of the lateral inguinal fossa through the deep inguinal ring. The hernial sac passes through the entire inguinal canal, has an oblique directions, and lies parallel to the inguinal ligament. The hernia sac is located laterally from the lower epigastric vessels. The hernial sac descends from the superficial inguinal ring into the scrotum. Elements of the spermatic cord are fixed from the outside to the walls of the hernial sac. The contents of the hernial sac can be both the insiders and the testicle covered with the peritoneum mesoperitoneally. Congenital inguinal hernia is in most cases illiteral on the right much more often than on the left. Direct inguinal hernias are characterized by the following signs. Protrusion of the hernial sac occurs in the medial inguinal fossa. The hernial sac does not pass through the entire inguinal canal, but only through its specific inguinal ring, which is located at the level of the medial inguinal fossa. Therefore, the part of the herniated sac has a straight direction and lies perpendicular to the inguinal ligament. The hernial sac is located medially from the lower epigastric vessels and is covered by the internal seminal fascia. The hernial sac is located medially from the spermatic cord of the non-commonly vaginal membrane and can usually penetrate to the base of the scrotum. During the operation of herniation, the elements of the spermatic cord are easily separated from the hernial sac. The hernial sac exists through the superficial inguinal ring into the subcutaneous tissue of the pubic region proper and does not descend into the scrotum. Since this is prevented by the location of the internal bundles of the muscle that raises to the testicle. The hernial sac is covered with skin, subcutaneous tissue, superficial and internal fascia, aponeurosis of the external oblique abdominal muscle, transverse fascia, and peritoneal tissues. Direct inguinal hernia is acquired and has the tendency to infringe. It is direct inguinal hernia is most often bilateral and is almost never seen in childhood. Internal oblique internal inguinal hernia is characterized by the following signs. Protrusions of the hernia sac the hernial sac passes obliquely from inside to outside through the superficial inguinal ring, annulus inguinalis superficialis, gets into the groin area, regio inguinalis. And the hernial sac is covered with peritoneal tissue and transverse fascia transversalis. Hernia repair, stages of hernia repair. To open the inguinal canal, an incision 8 to 10 centimeter long is parallel to and 2 centimeter above the inguinal fold from the point on the border of the lateral and middle third of it to the pubic tubercle. Dissection of aponeurosis of the external oblique abdominal muscle using a grooved probe, separation of the hernial sac from the lateral aponeurosis, flap of the external oblique abdominal muscle. Isolating the herniac sac from the elements of the spermatic cord, opening the hernial sac, reduction of the contents of the hernial sac in the abdominal cavity, suturing the neck of the hernial sac with an internal pouch suture. Cutting off the peripheral part of the hernial sac. Bobrov's method. The essence of the method is suturing with a nodal suture of the medial aponeurosis, a flap of the external oblique abdominal muscle, the lower fringe edge of the internal oblique, transverse muscles, and transverse fascia with the capture of the inguinal ligament from below, and the lateral aponeurosis, flap of the external oblique muscle in front of the spermatic cord. Degar's method. Hernia repair of oblique inguinal hernia by Spassko-Kotsky method. This is Martinov method. This is the scheme of applying of Kimbarovsky suture of the sagittal section. This is scheme of Bassini method. So this is all for our lecture for today. See you on next lectures.